We had to look at intellectual property of the raw image, how we would at the Douglas handle this aspect. And then we spent a fair amount of time looking into the different applications on the market. And we chose to work with AcuteNet for an exportable database that it allowed. Many do. Mainly bilingualism. We needed that for clinicians to be able to switch from French to English. If they're working with an English or French patient, to have this flexibility in real time. So this application allowed it. The HL7 integration was necessary, and the customization, I would say, feature of the software was very important for us. We were planning, really we were targeting the best buy-in possible from the clinicians. So we wanted to be able to customize the application. Important also for us was the calculation of the outcome scales, the CAPS, quality indicators. And we wanted also a software that had a care plan generator. The first version we had was a PDF format care plan, and clinicians had to convert it into a Word format. So this was something that we needed to improve, and we do now have a care plan in the Word format. This was a big buy-in moment for the clinicians. This is how it looks, the graphic interface of the application. You have all the sections, those that are completed, those that are not completed, and the ongoing section in blue. It's an autosave application. Once the answer is selected, it's being saved, so there's no loss of information as you're going through. Outcome scales and CAPS. For instance, all the names of the scales are done, the min and max information for both outcome scales and CAPS. And the assessments will show on a graph as we go through the various assessments over time. Quality indicators, and the what's in it for me is there for clinicians really to be able to send the level triggered for any CAP to a pre-formatted care plan. So what they end up with is a Word format that they can modify. So the first column is what the situation believes, the clinical team believes, and what are the recommended dimensions being identified. The second column is the version of the patient or the perception of the patient about it. So the clinician will add that. That's two separate columns. And then the objectives, and then the interventions that are being done. We had no plans in transmitting data to CAI during the pilot, and we don't for a few years until we have it deployed throughout all our inpatient units. We'll have work to do with our ministry to be able to do that. We can eventually, because of the application, contribute to the MACI with these three variables, these three dimensions that are there. Budget analysis, we were able to respect the budget that was allowed for this demo project, 65,000. You may understand it's confidential for further. We need to discuss with the ministry for the projection that we have for the next 5 years. So demonstration project itself, readaptation unit or rehabilitation unit, risk management unit, 16 beds, up to 30 patients followed in the community. Average length of stay 18 months. We had the training provided by CAI. Thank you to Karen Lewandai, Mr. Pelletier, who came to Montreal in March 2014. We had a Kaizen workshop, which is a lean methodology, in March with the clinicians to develop this workflow. Basically, it's 3 steps that the team came up with. They felt we can do it within 28 days, somewhere between 12 to 15 days for the assessment itself, shared between psychiatrists, nurses, and social clinicians. Once it's done, we close the raw image in the system, we get the outputs, we prepare the care plan being discussed with the patient, version 1 or 2, and then entered into our databases. So these are the numbers. 18 months between May 2014, October 2015. What it shows is that there's a regular, stable capacity of the team whenever a patient is admitted or whenever patients are being admitted, thank you, to complete RI-MH assessment. Although it has never been done before, the training, the preparation made it possible for the team to do it on a regular basis. You see 2 peaks. Guess why? January, after Christmas, after the holiday, we gathered as a team, we said, okay, let's catch up. In May, summer is coming, let's get ready. So this explains it. So it was the number of patients arrived on the unit and the number of completed assessment. This slide is the number of patients at the end of the month with the number of care plan that the team was able to produce, to generate. Before we did the project, the stats for this unit was about 5% of care plan being completed or being conformed with the hospital regulations. So it was a big accomplishment for the team to be able to generate and complete care plans on a very, very regular basis. We sent an anonymous questionnaire to clinicians, and the result, as you see, are very positive in terms of buy-in. 8 out of them, they were familiar with the RI-MH and the RI-MH software. They felt the RI-MH evaluation was well integrated into the practice. Project was a success. Useful for careful planning, 6 out of them, and so on. So the buy-in became very, very obvious from the team. So recommendations very quickly, to be able to establish a ministerial committee, a working group at the ministry level to foresee how we could implement RI-MH in other facilities. A second working group within our facility to deploy it in all our inpatient units within the next 5 years. Be able to get the financing support from the ministry. Be able to integrate research activities. Hearing from this morning presentations, there's opportunities for sure. And seek the support of our HTA provincial body that gives recommendations to the ministry. So that's the 6th recommendation. So that's about it.